You're watching Baptist Health's Resource Live, where our respected experts bring you timely and practical health and wellness information to improve your family's way of life. Hear healthcare that cares. This is Resource Live.
Hi, everyone. I'm Dr. Jonathan Fialco, Chief Population Health Officer at Baptist Health South Florida, coming to you live from the Baptist Health Newsroom. Receiving news that you have breast cancer can trigger many emotions. After receiving the initial diagnosis, many women are left thinking, what's next? We have with us today 3 experts from the Baptist Health family to talk about what happens after that initial breast cancer diagnosis. I'd like to welcome Dr. Louise Morel, who's the medical director at the Lynn Cancer Institute at Baptist Health's Boca Raton Regional Hospital. Great to have you with us, Louise.
Thank you. I'm glad to be here.
Dr. Jane Mendez, Chief of Breast Surgery at Miami Cancer Institute. Thanks for being here, Jane.
Thank you for having me.
And Dr. Anna Botero, who's a radiation oncologist at the Miami Cancer Institute. Great to have you with us, Anna.
Thank you very much for the invitation.
Before we dive into today's subjects, I want to remind our viewers to send us your questions and comments throughout the segment. We're here for you and happy to answer any questions you may have. Let's get started. And Louise, I'm going to direct the first question at you. When one is diagnosed with breast cancer, we're looking for the best physician-led team, which can be challenging. When you're looking to find the best team for your needs, sometimes the meaning of that's lost. What are the providers within a clinical care team, a cancer care team? If a woman's diagnosed with breast cancer, it's not just them and an individual. What do you and the team, what's the makeup of the team that manages breast cancer?
Yeah, I think every woman or nearly every woman I've ever met who has a new diagnosis of breast cancer, I'm sure my colleagues would say the same thing. The word by itself causes so much terror that you might not even be able to think straight. But at the end of the day, getting information and getting a plan is what gets that under control. In other words, getting really confident that you know everything that you need to know before you start treatment. And that is a team. And that's, I think, what you're referring to. I organize my thinking this way. Basically, when you have cancer of the breast, you have 3 goals. One is get it out, don't let it come back, and don't let it spread. It's that simple, because if that's what happens, then you're cured, right? If it never comes back, if it's out, it's gone. So those core things require the specialization of a surgeon who's going to get it out, of the radiation oncologist who's going to assure that it doesn't come back in the same area, and of the medical oncologist who is ultimately going to plan how do we prevent it from spreading. But because of all the breakthroughs and advances that have come in this field, there are going to be other people involved in your care, some of whom a patient might meet and some whom that we consider very, very critical to the team. Pathology, molecular testing, the kind of detailed testing that goes on requires a pathology team that has expertise in breast. Radiology, the person who is seeing this imaging, doing the multiple tests, really helping us assess what needs to be removed, is a critical part of that team. We consider the social worker, the nutritionist, the support services also critical parts of that team, even they're not making necessarily the treatment decisions. So for me, that's the expanse of the team. And then we've added genetics, because genetic information at the beginning of treatment may be important for some patients, increasingly so. So that's the core team: is medical oncology, radiation oncology, surgery, genetics, and then the other support people, as well as the team we rely on to detail out the treatment planning that any individual needs.
So clearly some of those resources will be very patient-centric, some might be behind the scenes, but it's a multidisciplinary approach to taking the individual with cancer and providing the best resources available, which is done at the Lynn Center at the Miami Cancer Institute. So a great start, great kickoff information. Jane, so going back to a woman's diagnosed with breast cancer, mammogram, usually the first test. What would a woman's experience be after they have a mammogram and the ordering doctor says, I'm concerned, this looks like maybe a malignancy? What additional testing might be done? Give an example of what the patient experience might be.
So, when you have a mammogram, just when you're completely symptomatic, that is a screening mammogram. And if something is detected on the screening mammogram, they might recommend additional views or to complement that mammogram with an ultrasound. And then the state of the art is to do image detected breast biopsies. So do a needle biopsy in the area where it's identified, let it be by ultrasound or by mammography, so we can lead to the diagnosis even before bringing that patient to the operating. That is the state of the art. And then once we have the diagnosis, depending on this particular case, sometimes we might need to order in selected patients breast MRI or magnetic resonance imaging so that we can get more information to define the extent of disease or to exclude any multi-center breast cancers, better assess the axilla, or sometimes if it's very dense breast tissue, even exclude any contralateral breast cancer. But the state of the art, as you already mentioned, and the gold standard is mammography complemented by ultrasound. So that's what we need to do.
The mammogram is, again, the initial screening test. Not all abnormal mammograms are malignancies, but one can expect further testing to define the presence of cancer, the kind of cancer. So follow up with that, if you would, regarding, are there different kinds of breast cancers? And when we talk about the stages of breast cancer, can you speak to what that means a little bit?
Yeah, first I'll talk about what the different types of breast cancer are. Number one, over the past 20 years, we really learned more about the fact that there's different subtypes of breast cancer. The most common is those that respond to the female hormones that respond to the estrogen and the progesterone. They're called as luminal A breast cancers. There's others that don't respond to any of the hormones or the receptors that we know about, the estrogen, the progesterone, the HER2. Those are known as the basaloid or triple negative breast cancers. And we have those that respond to the HER2 receptor, and those certainly have a specific target that we can aim as part of the treatment. When it comes to the staging, the way that we stage breast cancer is called the TNM. T stands for tumor size, N stands whether there's involvement of the lymph nodes or not, and M whether it's spread distant, what is called metastasis. So the earliest stage is at stage 0, and obviously the latest stage is at stage 4, when we already have evidence of distant spread. So the key is early detection.
So the detection, further imaging, stage it, find out the type, and then treatment plans are set based on that discussion.
Absolutely, and as Dr. Morel alluded to, Luis, that based on that type is when this multidisciplinary team that we alluded to earlier will tailor and individualize the therapy to the patient's own, comorbidities, to the patient's type of breast cancer, so we can start to do that planning. So it's the tailoring of the treatment.
So Anna, if you could pick that thought up. Jane mentioned hormonal therapy, chemotherapies, et cetera. Go through a little bit. What are the kind of different treatment options, at least in broad categories, for various forms of breast cancer?
Right. In general, the main pillars of the treatment is surgery, chemotherapy, radiation therapy, and what we call hormonal therapy, the pills for 5 years. And not all the patients qualify for those, but not every patient needs the 3 modality of treatment, and some of those patients may need only surgery and chemo, or surgery and radiation, or even chemotherapy and radiation, or even a single modality of treatment. As Jane mentioned, it's dependent on not only of the staging of the patient based on the tumor size, the status of the lymph nodes, and evidence of distant metastasis or not, but also we take in consideration the age of the patient. But more than the age, I would say that is the performance status of the patient, other comorbidities or other disease, and very important, what is the patient wishes, what do the patient wants. So I think that summarizing, basically very important that the patient is aware of early detection, consultation right away, finding the right team, having good communication, having good understanding, and not fear about the treatment that is coming, but not to believe that because we are recommending, let's say, surgery, chemo, and radiation is because she's the very advanced stage. Actually, many early stages, we treated with a combination of the 3 modalities of therapy. And not always surgery is the first one, and then chemo, and then radiation. Sometimes chemotherapy goes up front to facilitate or to test the tumor and to prevent the spread of the disease, and then the surgery, and then the radiation. So it's multiple potential treatments that, as Jane said, we have to tailor specifically for that patient. Not every patient is, just because it's the same as stage 3, has the same type of treatment for stage 3. Every single patient is different, not only because as a patient, as staging, comorbidities, as well as your own wishes, you know?
And again, I think as you're emphasizing, it's that individualized approach, having the opportunities, all the treatment options, having the multidisciplinary expertise in the assessment, and then tailoring a treatment plan, both, of course, to the pathology and the outcomes, but also to the patient's performance, their expectations, and their desires. And I think that's what separates the Lynn Cancer Institute, the Miami Cancer Institute from others. So I'm going to follow it up, Anna, with another question to you, which is a sensitive one. And it's something that I think speaks to all kind of diseases and people with medical illnesses, but let's bring it specifically to breast cancer. A lot of anxiety is driven from uncertainty. I think Louise even mentioned, we're going to come in, we're going to give you an assessment, tell you what's happening and what we can do for you and what one can expect. So if a woman gets diagnosed with breast cancer, abnormal mammogram leading to follow-up testing, what's the timing? Is that like, you know, oh my God, get it out tonight, I'll die if you don't by tomorrow? Give us an idea of how urgent should the diagnosis follow with assessment and subsequently treatment?
Well, obviously, to do all the testing for the diagnosis, for the right diagnosis, in a timely manner is time is important. Definitely, it's important, and I will say that the sooner that the patient starts the treatment, the better. But it's not like the tumor is growing, you know, in 24 hours. That's why it's so important to find the team, multidisciplinary, that you don't have to be going from one hospital to the other or from one physician to the other and waiting for appointment, that everything is coordinated. So as soon as the patient gets some plan of the treatment, some directive of treatment, some recommendations, I think that the sooner that the patient is scheduled, for example, for the surgery, after the recovery of the surgery, the sooner that they start the chemotherapy. And after the chemotherapy, specifically for radiation, we let the patient, you know, have maybe 1 or 2 weeks for recovery, and then we start the radiation. Typically, you know, it could be 2-3 weeks between each modality of therapy, but time is very important, and not by saying that is just to panic and say that I have to have the surgery tomorrow. There's very few cases that the tumor is aggressive, and certainly we have to move, you know, really fast. But in general, time is a precious, you know, important part of the equation, and definitely having the right team is what it really make a difference.
So the efficiency of the team, the coordination of your care, again, that's what separates the higher programs of which you all participate. I want to switch over to something Louise mentioned, which is genetics. And I'm going to split the question up first to Louise regarding family screening, and then over to Jane regarding the individual, what goes into the assessment from a genetic component. So Louise, when a woman finds out they have breast cancer, is it hereditary? What would you tell a woman regarding family members in terms of any types of evaluations?
Yeah, Jonathan, I think that I think that most women, in reaction to learning they have breast cancer, the very first thing is going to be, what's going to happen to me? What do I need to do? And then probably not a breath away is, what does this mean to my family? And so as a result of that, for a long time now, we've introduced quite early on that sort of family risk assessment and what is the role of genetic testing. And that, of course, has evolved quite a bit. I mean, most of folks have heard of the BRCA gene or the BRCA gene, and are aware of the Angelina Jolie story and of that testing being available. But again, trying to figure out when and how to incorporate that into treatment planning is an interesting question. And so we want to address it right away. In other words, we want to address by taking a family history, and then by speaking to the patient about what can be learned from the genetic testing. Sometimes learning a gene is going to influence treatment, surgical choices, especially in younger women. And so we incorporate that from the very beginning so that is important. But most of the time, that information is going to be more important for future screening, for family members. And ultimately, actually, in the last few months, an important article and bit of research on a targeted drug for specifically BRCA patients was published, and that data is now being incorporated to sometimes we're treating people based on their BRCA, not very often. And so that becomes another reason to do that genetic testing.
So Jane, if the genetic testing would be considered indicated for family members of someone with breast cancer, what if a woman has no family history of breast cancer and says, are there any genetic tests out there? Is there anything for someone without that family history that they should either A, be concerned with, or B, have done?
Yeah, Jonathan, this is a really important area because only 5% of breast cancers are explained by genetic predisposition. 10% of women have a family history, but with not a genetic mutation that we can identify that leads to action. And ultimately, 85% of breast cancers occurs sporadically. So the minority of women who get diagnosed with breast cancer have some either family history or genetic predispositions. It's a really small number. So I try to clarify that to the patients right from the get-go. We typically, as Luis alluded to, will take an extensive family history, and we try to stratify the genetic risk for that given patient. Women diagnosed with breast cancer below age 50, all are considered to be candidates for genetic testing, and we have a fabulous group of genetic counselors and geneticists, and we'll refer the patients for genetic testing. And nowadays, there's been an explosion of genetic information, and we can have genetic panels. And it's not only about surgical implications and treatment implications, but also about prevention for the future. Because somebody's identified with something like the BRCA mutations, either 1 or 2, we also have to then refer them for ovarian cancer and GYN oncology evaluation. So I think it's a very useful piece of information for that the patient can also prevent other potential cancers that might be associated with the particular gene that is identified. And there's many that are associated with breast cancer. And when it comes to other family members being tested, certainly the patient has the right to share that genetic information with their relatives. And then the genetic counselors are really helpful in then contacting those family members with the patient's permission, so that way they can get tested if indicated. But only 5% of women have such mutations.
So if a woman has no family history of breast cancer, clearly self-examination and mammography still remains the gold standard. Doing a genetic test and it being normal does not really mean
Correct.
You're not at risk.
But if they're below age 40 and below age 50 and they get now with breast cancer, with or without a family history, we will refer them for genetic testing.
Fair
Because
enough.
the younger you are, the higher the index of suspicion for a potential genetic mutation.
Understood.
I think
Anyone? Yeah, please, Louise, please feel free.
to add in is that what Jane just alluded to, that we now have panels of genes to test. So in the early days, by early is not that long ago, but initially we could only really test 1 or 2 cancer gene at a time. So BRCA1, BRCA2, for example. And the technology that she alluded to is that we can now do panels of tests, because you can literally do as many genes as you want to. And so a question that often comes to my attention is, if I was already tested in the past, do I need to do a test again with the updated test? And really, the answer to that question is generally probably yes. Depending on what the indication was, if you were tested before 2014, that did not include the panel. So anybody who did that test before that, you were basically, unless you were in a research testing setting, had the standard kind of sequence testing, and the panel testing became available after 2014. And we do have data that tells us about 5 to 10% of individuals who tested negative on the initial kind of testing will have some kind of a finding. Maybe not BRCA, maybe not as potent, but something that's useful to the family. So depending on the original indication for doing the testing, we are offering retesting.
So it's
Yeah.
not that if you had testing a long time ago, it was inaccurate. It's just that the panels and the genetic testings have expanded,
Yes.
that there's still benefit.
And-
And I do want to, hopefully you guys agree, caution that if one wants a genetic test, it's really important to have genetic counseling with it.
Absolutely.
And what the test shows, what it may show, what the implications are. Just getting a result in the mail may give wrong information, or at least wrong
You know,
action.
That and also the patients need to have an understanding of what the results might represent.
Right.
Because even if you have a genetic mutation, it's not 100% guaranteed that you're going to develop the cancer associated with it. And sometimes you find things about your family that you didn't even know. So you really need to be prepared by the genetic counselors to really be able to understand the information.
Yeah.
It's what I told all my kids: take statistics, understand probabilities, and empower you to make right decisions. So I appreciate that comment. Anna, we're talking about how unfortunately breast cancer is a disease of young women. When women are diagnosed with breast cancer at childbearing age, I know it's part of the decision in treatments. As we said, everything's individualized. What would be the effects of radiation or chemotherapies on fertility, or what is discussed and what outcomes are come from those discussions?
Well, overall, radiation should not affect, really the possibility for the patient to have kids. In terms of the chemotherapy, I think that every patient, any breast cancer patient that is at the childbearing age should be educated about how the fertility, her fertility could be impacted just, at the moment of the diagnosis, as well as in the future with the cancer treatment. So we have a really amazing oncofertility department, in which after we discuss with the patient, if they desire to preserve the fertility, we refer the patient to this oncofertility program. They evaluate the patient, and if the patient wants to proceed, they have to understand that at the minimum probably will be a month before proceed with the treatment, but it will be for the egg retrieval. After that, the patient start treatment. They also have to understand that during the chemotherapy, most likely they will protect also their fertility with some type of hormonal therapy, that is some injection with Soladex. Chemotherapy could last for 3 or 6 months. Typically, without this protection, still the young females could get pregnant. Probably 20-30% of them can still have, have a baby and get pregnant in the future. With this type of treatment, we might say that probably you increase your chances of preserve fertility, probably 50%, 50-50. And some patients have to really delay the potential or the probability of, getting pregnant for the 5 years of the entire treatment with the hormonal therapy. So definitely, I think that as I said at the beginning, every patient that is at childbearing age should be at least informed and educated about how this cancer treatment could potentially impact her fertility, in the present and in the future. But oncofertility is a very good option for them to have this discussion and go more over the details and let the patient decide if it's an option for them and if they really want to proceed with that.
You guys have done such a wonderful job explaining with obviously compassion and expertise, what the experience of a woman may be after that diagnosis. In the interest of time, there are some good questions coming in from Facebook, but we will have them answered on Facebook, not in real time, but feel free to keep sending your questions in and we'll have them answered. I'm going to ask one last question to Louise and then give everyone an opportunity for a final question. And again, it goes through, I think, the overarching theme. A woman with breast cancer, they're not going through this journey alone. Talk about how important it is to have that strong support system and what's provided by your services in that circumstance. And Louise, I'll turn to you first.
Yeah, I think you're right. It does fit the theme, right? We started with what's the importance of the team, and we started with the key sort of physician providers, because that's going to be the part that we always want to start with, is how do we cure this? How do we make sure you have every piece of information that you need? But I think everybody here knows and agrees how critical it is to have that sense of a team and the resources. Everybody is coming at this from a different situation in their life and different support people around them, but everybody needs to do this as support. Nobody has faced this before. This is going to be all new in territory, and having the psychological support, if it's a social worker support, if it is support groups, if it's nutritional, all of those pieces are absolutely as critical to the success of this as every breast cancer patient will tell you. And I think that comes back to the key of getting your care at a cancer center. It's just not like going to a doctor's office and going in and getting the treatment and walking out. It's about an entire team, including those resources that make this really a journey that includes the patient at the center and the team around them. And that is so critical to getting through this and the survivorship on the other side.
Thank you. Jane, any final comments, any thoughts?
Yeah, I think to follow up on Luis just said, it's patient-centered care. We've talked about the importance of the team, about also the importance of the support of the family, where I think it's sometimes that fifth element of care that we don't really consider, but it's so important to get the patient through the breast cancer journey. And ultimately, how to stress that the individualization of their care is critical in getting to where we are today, where if somebody is diagnosed with stage 1 breast cancer, we have 98.5% survival at 10 years. So it's a real testament to all these specialties coming together to accomplish that over the past 4 decades. So I think that's very important to stress to our patients.
Wonderful points. And Anna, final thoughts, comments?
Final point is that just kind of a message of hope for everybody, because breast cancer is kind of so common that it's a matter of when at some point we are going to be the ones to be affected by that. But just a message of hope, because patients that are early stage, they are really, really high chance to get cured. And even in the worst situation that patients are diagnosed with a stage 4, with more advanced disease or a spread disease, there's a lot of hope nowadays, thanks to the new medications that we have available, target therapy, immunotherapy, and such. And from the radiation therapy also, treatments used to be kind of really, more side effects than benefit. But nowadays, with the technology that is available, it's a very short treatment and pretty much no side effects, and really highly effective for local control, even from the distant metastases. So again, it's an individual basis, but there's a lot of hope, not only for being alive, cured, but in sometimes even for the quality of life, for excellent quality of life.
Beautiful. Well, thanks for your insights, guys. And to our viewers, you can connect with us on our social media channels. That's Facebook, Instagram, Twitter, and LinkedIn. And check out our resource blog for the latest news at baptisthealth.net/news. You'll find a link there to all the episodes of the Baptist Health Podcast as well. On behalf of everyone at Baptist Health, we ask you to please stay safe and say yes to the COVID-19 vaccine.
Thank you.
Find additional valuable health and wellness information on our resource blog at baptisthealth.net/news. And be sure to interact with us on our social media channels for live and upcoming events. Resource Live is brought to you by Baptist Health South Florida, healthcare that cares.